Right. So when reviewing and studying the cardiovascular system for the NCLEX, it is very important to know your cardiac dysrhythmias, to know what their EKG strips look like, to know the assessment findings for them, all of that good stuff. So a heart rate, I know we've been through this before, but a normal 60 to 100, sinus brady is less than 60, and then sinus tachy is 100 to 180 beats per minute. A little quiz: if you have done the cardiovascular system, the anatomy slide or PowerPoint, you should know what is the heart's natural pacemaker. So the heart's natural pacemaker is the SA node or the sinoatrial node, which sends out that electrical impulse at 60 to 100 beats per minute. With sinus brady, it's very important to remember that some people have a naturally low heart rate, such as athletes. Treatment for sinus bradycardia is only necessary if the patient is symptomatic. You would then, if they are symptomatic with bradycardia, you would then use medications to increase the heart rate. An example of those are atropine sulfate. All right, AFib or atrial fibrillation, you're going to have a heart rate of 350 to 600 beats per minute. So the atria quiver due to rapid impulses. The atria are not pumping as they normally would. They're just sitting there quivering. You will have decreased cardiac output. You're going to have increased heart rate. That increased heart rate is going to try and maintain homeostasis. So your main concern in a patient with AFib is the formation of blood clots, because the blood is just sitting there quivering, so it has the time to clot together. So due to the possibility of blood clot formation, treatment for AFib will always include an anticoagulant of some sort, usually Eliquis. On an EKG, a patient with AFib will have no definitive P waves. You're just going to see the QRS complex, but you're going to see no definitive P waves there. PVCs are premature ventricular contractions. So they are early ventricular contractions, which are caused by increased irritability of the ventricles. So different causes for PVCs include hypoxemia or electrolyte imbalances such as hypokalemia. PVC patterns. PVCs frequently occur in repetitive patterns. So you have, you can see them there. The RLT phenomenon is where the PVC falls on the T wave of the preceding beat, and this may precipitate ventricular fibrillation. So this is what a PVC looks like, this little spot here on an EKG strip. So it's important to remember that if a patient is experiencing PVCs, you want to only notify the MD if the patient complains of chest pain, if the PVCs increase in frequency, if they're multifocal, or if they're having different shapes, or if that RLT phenomenon is observed. Because remember, the RLT phenomenon may precipitate ventricular fibrillation. So if that RLT phenomenon is observed, you definitely want to notify the MD. Ventricular tachycardia, you're going to have a heart rate of 140 to 250 beats per minute. There are 3 different types. So you have stable, unstable, and pulseless. Stable ventricular tachycardia, you're going to administer oxygen and antidysrhythmics as prescribed. For unstable, you're going to administer oxygen, antidysrhythmics. You may want to prepare for cardioversion, and the doctor may even ask the patient to cough hard in an attempt to convert the rhythm. And then pulseless VTAC is going to require defibrillation and CPR. So ventricular tachycardia may be present in only 3 or less beats. It may be very limited, or it could be sustained as well. So it's important to know that ventricular tachycardia can lead to cardiac arrest. A stable patient with ventricular tachycardia is a patient that has a pulse, they're asymptomatic. An unstable patient is a patient that still has a pulse but also has signs of decreased cardiac output, such as hypotension and hypoxia. So by coughing, a cough is an example of a vagal maneuver that can often be used to terminate dysrhythmias. This is what ventricular tachycardia is going to look. It's kind of like a sawtooth pattern. You're going to see this on the EKG. Okay, so ventricular fibrillation is very disorganized, rapid rhythm in which the ventricles quiver. So there's no cardiac output in ventricular fibrillation, because remember, the ventricles are the left ventricle is going to pump the blood back to the rest of the body. So when that ventricle is just quivering, there's no cardiac output. This is fatal if it's not resolved in 3 to 5 minutes. The patient will go unconscious. They'll have no pulse, blood pressure, or heart sounds. So treatment is to initiate CPR with defibrillation. So it's very important to know the steps of CPR. You're going to follow the steps of compressions, airway breathing. Your compressions are going to be 100 to 120 per minute at a depth of 2 inches. You will need to be CPR certified for your career as a bedside nurse or a nurse in the clinic, wherever you end up. So I definitely recommend going ahead to get certified. So treatment for dysrhythmias, you have vagal maneuvers like the coughing that we were talking about. So the patient can either be asked to cough or bear down. A vagal maneuver can also be in the form of a carotid massage, in which the doctor would massage the carotid artery to then see if a change in rhythm occurs. You have both cardioversion, which is a lower amount of energy than defibrillation, and then you have defibrillation. So with the cardioversion, the defibrillator is synchronized to the patient's R wave. You want to avoid shocking on the T wave. So discharging the shock on the T wave could induce ventricular fibrillation. So you definitely want to avoid that. Defibrillation is used during pulseless ventricular tachycardia and ventricular fibrillation. So before defibrillation, you want to ensure that the oxygen is cut off and that no one is touching the bed or the patient to prevent that subsequent shock. So if a patient has a diagnosis of atrial fibrillation or aflutter and they're having an elective procedure done, it is important that the patient receive anticoagulant therapy for 4 to 6 weeks prior, and you'll want this patient to receive a TEE to rule out the presence of clots in the atria prior to any procedures. Also in the realm of treatment for dysrhythmias, you have an AED or an AICD, or an automated implantable cardioverter defibrillator. So with an AED, shocks are only recommended for pulseless VTAC and VFib, whereas with an AICD, this is usually only used in patients who have been unresponsive to medication therapy and have episodic life-threatening dysrhythmias. So the implant is actually inserted into the left pectoral region. It detects episodes of VTAC or VFib, and it can deliver 25 to 30 joules up to 4 times. Whenever a patient has underwent and has an AICD in place, they, of course, want to avoid any contact sports to prevent dislocation or damage of the leads. You want to keep a journal with any shocks that it may deliver, and always call the primary care provider or the MD when shocks do occur. All right, so pacemakers. So a pacemaker is a temporary or permanent device that's implanted. It maintains a heart rate when the SA node fails to do so with electrical stimulation. So you have a synchronous or demand pacemaker, which senses the patient's rhythm and only paces if the heart rate falls below a set rate. And then you have an asynchronous or a fixed rate. It paces at the preset rate no matter the patient's intrinsic rhythm. So a permanent pacemaker is usually inserted into the subcutaneous pocket below the clavicle. The pacemaker is programmed initially but can be reprogrammed later non-invasively. Lots of patient education is included in the placement of a pacemaker, including the reporting of any signs and symptoms, no contact sports, keep a diary of any dysrhythmia that may occur. You need to educate the patient on how to check the pulses, etc. There is also a such thing as temporary pacemakers. They're placed on the outside temporarily until a permanent placemaker can be inserted. Usually temporary pacemakers are only used in emergencies. The vital signs are always monitored, and then cardiac monitoring is done continuously for the patient with the temporary pacemaker.